Good morning, ladies and gentlemen. My name is István Baradács, and I would like to present the 9 months progress in my PhD topic, which is the targeted therapy in ovarian cancer. First, let me introduce our team. I am a resident doctor at the Obstetrics and Gynecology department. My supervisors are Balázs Lindner and Ferenc Bánhidi. Our SMS is Brigitta Teutsch. My vision is that the molecular targeted treatment could completely change gynecological oncology, and the mission behind my work is to learn about the possibilities given by this treatment and bring the knowledge back to the bedside. We have started to work on 2 different projects. The first one is the efficacy and safety of PARP inhibitor therapy for advanced ovarian cancer. It's a meta-analysis. And the second one is investigating the efficacy and safety of anti-VEGF and the PARP inhibitor combinational therapy for ovarian cancer. It's also a meta-analysis. Let me start with our first project. I have finished the draft of the article, and with the help of our supervisor and SMS, we will send it to internal review in the next weeks. And the planned journal to publish is the Gynecological Oncology. It's a D1 journal. Let me give you some background for our project. Ovarian cancer in 75% of the cases is diagnosed at an advanced level, and with the standard chemotherapy treatment, relapse occurs in over 70% of the cases. These facts highlight the need for a new therapeutic pathway, and based on recent research, PARP inhibitors could be these drugs. These drugs are facilitating the DNA double-strand break accumulation, and they are highly effective in the BRCA mutation and other homolog recombination deficiencies in the cancer cases. Our aim is to assess the efficacy and safety of PARP inhibitor therapy in advanced ovarian cancer. Our clinical question is, do PARP inhibitors provide better progression-free survival for ovarian cancer patients? Or populations are the newly diagnosed ovarian cancer patients and relapsed ovarian cancer patients. Our intervention is PARP inhibitor maintenance therapy. The control is the placebo, and our outcomes are progression-free survival, overall survival, and adverse events. Our hypothesis is that the PARP inhibitors provide better survival and are well tolerated for the patients. We ran our systematic search and selection in the middle of April. It was an updated search, and we found 21 eligible full text for our meta-analysis. The statistical methods resulted in approximately 80 forest plots. I would like to show you the most important ones. The first one is examine the progression-free survival in the recurrent tumors, and the subpopulations were the total population, the BRCA mutated, the germline BRCA mutated, and the BRCA wild type population. You could see the pooled hazard ratios here and the level of heterogeneity here. As you can see, these are clinically and statistically significant benefits for the usage of PARP inhibitor therapy for the relapsed ovarian cancer patients. For the next one, here, the newly diagnosed patients were examined, and the pooled hazard ratio is 0.36. It's also a significant benefit for the PARP inhibitors in the newly diagnosed tumor type. And also the heterogeneity was 0%. The third result slide is showing the adverse event in the recurrent tumor types. These are the outcomes to measure the tolerability of the treatment, and obviously with the maintenance treatment compared to placebo, the rate and the risk of adverse event was increased, but I will show you some interesting things. It's known that the PARP inhibitors have myelosuppressive effects, and hematological toxicities are well known for this treatment. The increased level of adverse events doesn't mean that the treatment should be discontinued immediately, because these numbers show that the dose modifications are, in the vast majority of the cases, is enough to continue the treatment and fulfill the maintenance period for the advanced PARP inhibitor treatment. As a summary, I would like to describe the strengths and limitations. Our meta-analysis is only based on RCTs. We have homogeneous populations and clinically important subgroups, and the overall risk of bias was low. On the other hand, there were minor differences in the interventions, and in some cases the overall survival data was unavailable, and most of the cases the follow-up time was short. As a conclusion, the PARP inhibitors showed significant progression-free survival benefits, and also increases the risk of serious adverse events. Both primary and recurrent ovarian cancer patients should be treated with PARP inhibitors, and the adverse events doesn't immediately mean that the therapy should be stopped. And there are several unclear questions. That the first one is the survival benefit for the BRCA wild-type population. The other one is the question of timing of the treatment. And the third one is that the question is what's happening if this treatment is not working. And the answer for the future could be that the combination therapy with other targeted treatments. Let me continue with our second project, investigating the efficacy and safety of anti-VEGF and PARP inhibitor combinational treatment for ovarian cancer. The background is quite the same. As I said, the ovarian cancer is characterized by late diagnosis and high relapse rate. The chemotherapy have limiting factors like neurotoxicity, myelosuppression, and platinum allergy. And this combination could hold the opportunity for our patients to have a chemotherapy-free treatment for this cancer. And on top of that, these two drugs improve each other's clinical outcomes. Our aim is to assess the efficacy and safety of the combination treatment for ovarian cancer. Our question is that does the combination therapy provide better survival for ovarian cancer patients, or patients are women with advanced ovarian cancer, or intervention is the combination therapy, control is the PARP inhibitor therapy, and outcomes are progression-free survival, overall survival, and adverse events. Our hypothesis is that the combination treatment provides better progression-free survival and are well tolerated for the patient. It's a relatively new topic for the preliminary search. We have to do the whole search process and data extraction process, and we found 7 eligible full text, and we sent it to the statisticians, and as we have a green light from them, we will update our project and start to write the article. The planned submission dates are July and September for our project, and I would like to close the presentation with a quote from Hippocrates: "Wherever the art of medicine is loved, there also a love of humanity." Thank you.
Congratulations for your nice work. My question would be regarding your second project and the population. As I understood it, have you already done the selection, so you know the articles? And well, like in oncology, the pre-treatment is very can have an effect to the intervention that you would like to assess. Which studies did you include? Did you draw a direct line that you include first-line studies in the intervention group, or did you allow previously treated patients with advanced ovarian cancer, or are you planning to perform some subgroup analysis based on that?
Yes, thank you for your question. Basically, we are planning to do the same subgroup analysis as we did with the first study. So we also included the newly diagnosed tumors and relapsed tumors, and we will divide the whole population to subgroups and do the statistical analysis by that way.
Thank you. Probably I was missing from the group meetings, and that's why I don't know exactly regarding your second project. Are you planning to do a network analysis for that? Or I remember that there are multiple comparisons, like only chemotherapies, only PARP inhibitor, or compared to the combination therapy. But are you planning from 7 studies? Actually, you could do that.
Yes, thank you for your question and advice. We're discussing it from September with Brigitte that a network analysis could be great for this population and for this topic, but the second project is not a network analysis. It's only restricted to this combinational treatment. And maybe for a third one, we could go for a network analysis, because there are several targeted treatments. These each one by one, we couldn't do a simple meta-analysis for them, but a network meta-analysis is another way and a good idea. Thank you.